one of the main reasons that we have contributed the understanding to is molecular heterogeneity of the disease. And what I mean by that is um, classic disease categories, like, for example, HER2 positivity, was once thought to be sort of homogeneously present within a patient's disease burden. And we now understand that there are a subgroup of patients that, although they might be HER2 positive in their primary tumor site where the disease started, if you were to look at their metastatic disease, it doesn't. And this was not that new. It had been just found also in breast cancer, but to a much lower rate. And so the disease itself is much more heterogeneous within patients, not only between patients, which we now recognize as immense, but also within patients. And so, in addition to that spatial heterogeneity, where just at baseline, I was talking newly diagnosed disease, where you would have discordance of biomarkers from primary tumor to metastatic site, you also have, of course, something that was a little bit more recognized at the time, which is evolution over time, where patients, especially if they're given a targeted therapy, will impose a selection pressure to select for disease, and often that is negative or does not harbor that particular biomarker later. And they're interrelated because spatially, if there's something that's missing a biomarker at baseline, that's the one that emerges later. Temporally, it's just there at the beginning. Sometimes you can see it, sometimes you can't. And so all of these things coupled together have made improving biomarker based targeted therapies challenging to move forward and to have positive studies.